Hello, everyone, and welcome. I'd like to begin with something our guest has emphasized in previous interviews, that parents should not walk this journey alone, and that finding informed advocacy group and parent communities is essential. That message inspired us to build exactly that, a parent-led advocacy group seeking to help parents ask better questions and advocate more effectively.
It is a true honor to welcome Dr. ریچارد Frye, a board-certified child neurologist and internationally recognized autism researcher. His work has focused on biological aspects of autism, including cerebral folate deficiency, mitochondrial dysfunction, immune pathways, and metabolic activity. His groundbreaking work is giving hope to countless children around the world and is changing the way autism is approached. Through his book, The Folate Fix, that we have here, he has made this important topic accessible to parents and physicians worldwide. Dr. Frye, thank you for joining us.
Yeah, my pleasure.
To start, and for parents who may be hearing about this for the first time, could you tell us a bit about your research and how Leucovorin may help children with autism?
Yeah, so the discovery is very interesting. It goes back actually to the turn of the century when Dr. Rainmakers, who was working in Germany at that time, he's a Belgian, child neurologist, discovered something called cerebral folate deficiency. He found that there were some kids that had neurodevelopmental disorders that weren't responding to any treatments. He did something called a lumbar puncture or spinal tap to look at the fluid that surrounds the brain to see if the chemistry was good or if there was any abnormalities. He had teamed up with one of the world's experts in the biochemistry of the brain and examined whether there was a problem. And he found that these kids had low folate in their cerebral spinal fluid, the fluid that surrounds the brain. This suggested that for some reason the brain wasn't getting folate. And we know that folate is so very, very important. It's important for our cells to work. It's important for our cells to divide. It has so many critical, functions that without good levels of folate, the brain really can't function. And actually, some of these kids with their brains were actually getting smaller and not growing. He didn't know why that was. At first, he thought that there was a problem, a genetic problem with the carrier that brings folate into the brain. The brain is a protected area of the body, and so everything that goes in there has to be brought in there, specially because it's a highly regulated environment. So he looked at something called the folate receptor alpha, which is that main mechanism which brings folate into the brain, and he couldn't find any genetic problems. But it ends up across the pond in Brooklyn, New York. Dr. Edward Quatros was studying the folate receptor alpha, but infertility. He had found that some mothers had these antibodies, autoantibodies, that is an antibody that usually protects you against a bacteria or virus, for some reason was attacking the body, specifically the folate receptor alpha, and that it was affecting fertility because, of course, folate's very important, during gestation, during, prenatal development. So he teamed up with Dr. Rainmakers, and they found that, I believe, 23 out of the 25 children that Dr. Rainmakers was studying had this antibody, and they surmised that there was a problem getting folate into the brain because of these antibodies. And then, one of the things that we know, luckily, we kind of know how to get folate into the brain because we use it to help mitigate the side effects of chemotherapy in cancer treatments. So we use a special type of folate called leucovorin. It's been used for over 80 years, and we know that it can get around blocks and get into the brain. So he treated these children with leucovorin, and some of them made a dramatic recovery. And this was published in the New England Journal of Medicine in about 2005. Now, one of the things is that it just mentioned as an aside that, some of these kids had symptoms of autism. So, about the same time is when I had finished residency and I was out there specializing in autism. I kind of fell into it because I had done a fellowship in behavioral neurology and learning disabilities. And that was a time when autism was being more and more recognized. So we'd have all these kids come to the neurology department, and the parents would say, well, my kid has autism. I think it has something to do with the brain. I want a neurologist, to take a look. So nobody really knew too much about autism. So what do you do with those cases? You give them to the fellow, So I suddenly got all these cases, and I had to start figuring this out. And as I went on in my career, of course, every time, I got a job, I was in academia for a long time. So I'd go into a department and my colleagues would say, oh, you know something about autism? Because I don't know anything. And I got a whole clinic full of them. So you can have all of mine. So before I knew it, that's the only thing I was seeing was kids with autism to try and evaluate them neurologically. And so when I saw the work by Dr. Rainmakers and Quatros, we said, well, some of the kids that weren't recovering, maybe we should do lumbar punctures on. We had a very talented neuro-interventional doctor who could do these lumbar punctures very well and safe. And so we started finding that some of the kids did have low folate, and we treated them with leucovorin, and some of them made, some substantial recovery. So knowing that that there was this blood test that we can measure this thing called the folate receptor alpha autoantibody, myself and my colleague, Dr. Rossignol, said, well, how many of these kids are running around in our clinic, with this antibody? Is it a rare case, maybe 1 or 2, or is it 100%? We don't know. So we did our first systematic study where we looked at this in kids in our clinic, and we found that 75% of them had this antibody, and that we found those with the antibody, if we gave them leucovorin, we found that they improved in language, particularly, but other things too, attention, stereotype behaviors. And of course, that was what we call an open label study, where the patients knew they were getting the medication. We did have a control group. We had a waitlist control group. So the next phase was to do what we call a double-blind placebo-control study, where nobody really knows if you're getting the active drug or, inactive. And at that point, I had moved to Arkansas Children's Hospital, where the first thing I did was launch that study, and that was published in 2018. That showed that in our study that indeed children with autism responded to leucovorin in general with improved language, and then if you had the folate autoantibody, that it predicted your response significantly. And so that's where, when we had first made the discovery in our first paper, myself and Dr. Rossignol, we thought that everybody would be prescribing it the next year. Yeah. Mm-hmm. And now it's 15 years later, and at least people are knowing about it now.
Yeah. But now they'll know about it, definitely.
We're gonna help it.
Yeah. And
so we're very, we're really happy that there's raised awareness has been raised about it, and we wish that there wasn't as much controversy, but I think in a lot of ways it's a revolution, not so much just leucovorin, but to say that autism is treatable. This is something that many people don't believe, is that you can actually treat these children. And the reason I think, that people don't believe it is because of the two, facts that, people learn about autism, doctors learn about autism, is that autism is genetic and that genetic disorders aren't treatable. And both of those facts are false. They're patently false. And it keeps spreading like that, so the reason that autism is thought to be genetic is it's highly heritable. It seems to be a highly heritable component. And genetics is one way of having heritability of certain traits. It's not the only way, but it's one way. So it's automatically assumed that it's genetic, it's heritable. But the problem is, and we just recently published 2 papers on this, that if you look closely, you find that almost half of the kids with autism have some type of gene mutation, that can contribute. But the great percent of those, 95 or more percent, are what we call de novo mutations. They're not inherited. So the idea that the genetic disorders adds up to the heritability is absolutely false, because these are de novo mutations. And where does de novo or new mutations come from? They usually come from environmental insults, lack of nutrition, other types of environmental factors. So the fact is, it's hard to kind of keep those two ideas in your head sometimes, that autism is genetic and it's also very environmental too. Yeah. And so this that assumption is very false, or at least it's incomplete, to think of it that way. And that's one of the frustrating things, is many times when a person finds a genetic mutation, they stop trying to treat, because they can't do anything about genetics. And that's not true. We have many children with genetic disorders that respond to all these same treatments that we use for kids without genetic disorders, including cerebral folate deficiency. We find a lot of kids with genetic disorders have cerebral folate deficiency. And we think that's just because, if you have a genetic disorder, it causes, your cells not to work optimally. And if they don't work optimally, sometimes things go wrong, like not getting enough folate into the nervous system. So those two things, I think, they have to change in our thought pattern. And the idea that, somebody, of power has said now that autism is treatable is really, I think, revolutionary.
Yeah. Mm-hmm. Yeah. Autism is treatable is a great message. Yeah. Yeah. Very inspiring. Yeah. Very.
Thank you. Thank you for your response. And can you share where have you seen benefits from this treatment? I mean, can you share some success stories that can inspire parents?
Sure. Yeah. And that's one of the things that we did in the book that you mentioned, the folate fix. We have 12 stories from our parents about their journeys, and most of those are pretty tough journeys that they describe, and I hope it's inspiring to parents to keep going. Very. Many times, these parents had to, surmount such obstacles. But luckily, as the message gets out, it's getting somewhat easier. And so if you look at the numbers in our study, in our placebo-controlled study, our double-blind placebo-controlled study, we found that 75%, so we know that about 75% of the kids have the antibody. And we found something called a number needed to treat of 1.8, I believe it is. Yeah. And so that means that you have to treat 1.8 patients to get a dramatic response. So if you do the numbers, that's about 40%. That's about 40% of kids with autism. So that's a gigantic number. Yeah. What do we see in practice? Well, on the news, you see these kids that start, saying words in 1 week. Those are, not the typical case, but it is about 5-10% of the kids. We see have this really dramatic response to it. Many of the other kids have, it takes a little bit longer. In our study, our measurement points were 3 months apart. So we always remind parents, well, we waited 3 months, so not 1 week, and so, so sometimes it does take time. And other kids have a little bit more of a lackluster response, and it takes some time, even months to years. But we do see this uphill, improvement in language that continues. Mm-hmm. Now, one of the reasons I say, that, parents should do this at home, as to say, is that, children with autism are very complex, and when a child comes into our clinic, we look at every aspect of that child, because they have problems with sleep, they have problems with GI issues, they can have seizures, subclinical seizers, nutritional deficiencies, many other problems that need to be addressed, before the leucovorin is going to work optimally. Yeah. It may work suboptimally. We know something that B vitamins in general cause a lot of energy, So some kids are hyperactive to begin with, so you give them a little bit of other energy and it's a little bit of tough. We know that gets better with time, but sometimes, it's tough to push through there. So there's a lot of things that you have to do. Unfortunately, it's not always that simple.
Mm-hmm. Yeah. Is there, by the way, any suggested way to do it? I mean, like starting with dietary changes, then going to supplements, and only then starting with folinic acid?
So, what we do is first we work on sleep problems. Sleep is very, very important. I think it's kind of recognized how important it is. So you have to fix sleep. You have to fix any GI problems, right? GI and nutrition, because if a child isn't absorbing, the nutrients they need, they're not going to grow. Their brain's not going to work. And, if they have GI pain, they're not going to be in a good mood, and they're not going to want to learn really work well with their therapists. They're going to, and you're going to have to spend all your time, trying to fix behavioral issues rather than being able to attend. We do overnight EEGs to make sure there's no, seizure disorders, especially during sleep, because they're not going to respond if that's an issue. Also, so we kind of start at the basics and then work up. We also look for mitochondrial issues. That's another very important metabolic disorder. And if the mitochondria isn't working, sometimes leucovorin won't work either, because we talk about the folate receptor alpha autoantibody, the Frye test and such. But there's two reasons for folate not to get into the brain. There's actually three reasons. You can have a genetic problem, so those do exist, but those are rather rare. You can have the folate receptor antibody, but also you can have a mitochondrial issue. So one of the important concepts to understand with this is that this folate receptor alpha, why it's so important, is because the folate levels in the brain are 2 to 3 times higher than they are in the blood. So the folate receptor alpha essentially pulls folate into the brain. So it's an active process, and it has to have energy. And so if your energy systems aren't working, it's not going to work. And that goes to the treatment. So when we treat with leucovorin, essentially what we do is we go around the folate receptor alpha. We go through something called the reduced folate carrier. But the reduced folate carrier, doesn't pull folate in. It's kind of like a tube, So essentially what we have to do is we have to push folate into the brain. So we have to get the right type of folate, and we have to increase the levels in the blood higher than they normally would be and push it into the brain. And that's how we solve the problem.
Mm-hmm. Yeah, and there's a question that we hear very often about age. From what age can folinic acid be used? Can infants even be treated? Is it common?
Yeah. So one of the things is the idea of cerebral folate deficiency. It seems to present or show up differently at different ages. And so we've gone through in the book all the different, studies. In infancy, it usually shows up as, or I'd say in the neonatal period, very early on, it shows up as seizures. It's been described in what we call myoclonic epilepsy, which is very severe epilepsy starting at birth. And then very early on, it can show up as refractory epilepsy of all types. And in fact, that was when I first started using leucovorin, was actually way before autism. And one of my first case reports was on a child with what we call Folinic Acid responsive seizures. That was, I think, 3 or 4 months old. We think in the first year of life that it shows up as more of classic cerebral folate deficiency, where you have regression and you may develop sometimes seizures, sometimes a movement disorder, sometimes what looks like almost acquired cerebral palsy with spasticity. And then we think if it's a little bit later on, second, first or second year of life, maybe third, it shows up like autism. And then what we found is that in the older childhood and adolescence, it seems to be associated with the PANS-PANDAS group. So we published a paper where we found that kids that were diagnosed with PANS and PANDAS, 60% of them had the folate receptor autoantibody, and they seem to respond to leucovorin. So we think it's hiding in there. In a young adulthood, Dr. Rainmaker has published another paper where he showed that individuals with refractory schizophrenia may have and that are young adults may have cerebral folate deficiency in response to leucovorin. And then into adulthood, Dr. Lisa Pan, who is at University of Pittsburgh, had showed that it seems to show up as refractory major depressive disorder with suicidal ideations.
Oh.
So we think depending on the age, it has actually different manifestations.
Oh,
but
you've seen? You've seen?
What's that? Yeah, and
benefits in adults?
Yeah. So again, a lot of those things are still where we were, 15 years ago.
Wow.
On kind of case reports and case series. But it does look very like it has, promising treatments throughout life. And then there's other reports that suggest in a lot of neurodegenerative disorders, folate may be a major issue too. So I think we're just scratching the surface with treating kids with autism. And it shouldn't really be surprising that folate has such a major, role. I think that people just don't understand how important vitamins are. They take them for granted, but that's the basis of what makes our body work. Are these what we call cofactors that make the machinery in our body works. It's like not having enough oil in your car. It's going to burn out.
Okay, so teens and adults should not lose hope. Yeah.
Oh, definitely not. And we've seen responses, at every ages. In our first double-blind placebo-controlled study, we had a wide range of ages. And what we did find is that even, we talk a lot of times and people are impressed that the kids that don't say any words start saying words. But we find that even the older kids that had poor language use, that when they went on leucovorin, they started to have better receptive language. They understood more complicated concepts. They were able to use more sophisticated language. So it seems to help almost at every level. And a lot of times with the older kids, we see better attention and other cognitive issues, too, that improve. So, one of the great things is that it's a very safe treatment. There's all of this rhetoric saying that we don't know the safety of it.
Yeah.
This is probably one of the longest medications we've used. I mean, there's others, but leucovorin has been used for over 80 years in treating, patients. There is no, significant side effects associated with it. Anything that, any of the studies that have shown side effects in the studies have really attributed them to the chemotherapy when it's used with chemotherapy.
Yeah.
So it doesn't seem to have an additive effect. And all of the studies in autism, there's nobody has reported significant in the placebo-controlled studies, the controlled studies. There has been no reports of increased adverse effects with leucovorin. Again, B vitamins in general do make you, give you energy. So we do see sometimes in the beginning, we do see some hyperactivity. If you give it too late in the day, sometimes some sleep disturbance, but you can treat those and those go away. And those aren't serious things. Those are things you can deal with. And in fact, what we found when we actually looked at it closely, we found that it was no different than the placebo in our placebo group. So, I think it may very well be due to leucovorin, but it's something that's transient and can be controlled, and it's not dangerous. And so I think it's a very safe treatment to use, especially, if you work with somebody that knows how to use it. Now, the one thing we have found is that the commercial forms of leucovorin do have additives in them.
Yeah.
And so we don't really prescribe any commercial forms anymore because we found that either they can cause adverse effects as far as behavioral effects, or they are just not effective. And we think that has also to do with, it may have to do with degradation of the product if it's stored for a long time, non-protected. So, there's a lot of things we don't know. So that's why, one of the things we're working on is to develop a specific leucovorin that's just for children with autism, that's made for their needs, so that they can have.
Yeah.
Yeah. They're, you have, go ahead.
Yeah, you mentioned compounded leucovorin, but it's generally just not available to us. What would you suggest to parents to do when compounded is just not an option?
I mean, there's it is an issue. So it's you have to look for formulations that have minimal excipients, minimal additives. So we know that there's one form in the United States, one commercial form that seems to be clean, and in Europe. Almost all the commercial forms have additives in it. We have one form that is being developed in Switzerland that hopefully will be on the market soon in Europe. That has minimal excipients also. So it is quite an issue, that's what's one of the things we're trying to approach, because it is tough for parents to get the good forms of leucovorin to try it, and then you don't know if you just try it, you don't know if some of the effects that you've seen or lack of effect may be because of that. So it's important. Yeah.
Every kind of them is hard to come by. It's very the inventory is like not there. We're having a rough time finding leucovorin in the pharmacies here.
Any kind of leucovorin.
Any kind. Yeah. So
and we've had problems too with the shortages. Yeah, and that's another reason. Yeah, we go with compounding pharmacies that know that we're going to be sending the prescriptions that are prepared for it, because the regular pharmacies aren't prepared for this rush of leucovorin. Yeah,
that's nice. Okay, so Folinic was used in the French study. What is your opinion on it? And it's very popular among the members of our community.
Yeah, I mean, I think it's a form. It showed effects in the study, so that's really good. It does have additives in it, and some kids do very well with the additives. It doesn't bother them, but other kids, it does. So for some people, sometimes we try the commercial form, and if it works, fine. Then if it doesn't, we move over to the compounded form, and so that's a strategy, that you can use. A lot of people, there's a lot of also kind of criticism about the studies that have been out there. Now we have, 5 randomized controlled studies. Have all, most of them have used what we used in our original study, but others have used lower doses, like the French used 5 milligrams twice a day. And they've all shown positive results, and so there's a lot of criticism that the studies, used variable, methodology, variable dosing, variable outcomes, but they're all positive, Usually you always talk about the variability when you have negative studies.
We shared
so now we have 5. What's that?
We shared with you before our meeting today. We shared with you a formal position statement from the Society of Child Neurology and Development, which are actually they're announcing they are opposing the use of folinic acid in children with autism. And they claim that there is insufficient evidence supporting folinic acid as a treatment for autism, that testing for folate receptor alpha antibodies or CSF folate levels is not recommended, They're also saying that positive antibodies results are common and should not independently guide treatment decisions according to what they are saying, and that existing medications like valproic acid, the sulfate, should not be altered based on theoretical effects on the folate cycle. That's what they are saying, and we would really like to know what do you think about these claims in light of your clinical trials and the extensive real-world clinical experience that you have.
Yeah, respectfully, I think it's misguided. And I don't. I really, I'm a child neurologist, and it's really hard for me to understand because, that, as I said, I started using Folinic Acid, Leucovorin, for seizures, and we know for refractory epilepsy that it can be very, very helpful. So, neurologists are they should be very adept at using these vitamins for refractory epilepsy, and so they should be comfortable with it. So, first of all, the idea that there's insufficient evidence. I would agree that there needs to be a large, confirmatory study, and that's something we're trying to plan to do. But right now, for randomized control studies, there's 5 studies from 5 different countries by 5 different researchers that are all positive, and right now, it represents over 250 patients that have been in randomized control studies. That is equal to the number of children that were used to get approval for risperidol by the FDA in the United States. So you have the numbers, okay? Mm-hmm. And risperidol has significant side effects. It has its place to be used when it needs to be used, but it has significant side effects. And we know that. So if you're looking at 2 medications, one that the safety is well known and it's very safe, and one that the safety is well known and it's not good, which should you use first? I don't know. To me, it seems like an easy decision.
For all of us.
Okay. 2, the folate receptor alpha antibody, the FRAT test. Okay, the FRAT test, is something that needs to be developed more. We're in something else that we're working on. But, our study, and I believe it was the Indian study, showed that that it was predictive. It predicted. And we have another paper through our clinic, or of an open label trial, where we showed that the binding antibody was significantly related to response to leucovorin. Okay. So, you have those clinical markers. Then there's 2 studies, my study and one by Dr. Rainmakers, that shows that the blocking antibody is proportional to CSF folate levels. Okay, so we've shown that mechanistically it's really important. So the idea that the FRAT test is not perfect, I'll take that as true, and it needs to be developed. But is it predictive? Yeah. I mean, we already have studies that show that it's predictive. Theoretically, it's predictive. Then in addition to that, we have the animal studies that have been done by Dr. Quatros. He has made a mouse model that shows that these do affect folate moving folate into the brain and folate across the placenta. Too. So, there's definitely evidence. Okay, you should not do a lumbar puncture. Let's see, that's insufficient. So I would ask the society to look at our systematic review and meta-analysis that we published in about 3 years ago. And we found that if you look at the studies, these aren't our studies, we reviewed other people's studies, including one from NIH, the prevalence of cerebral folate deficiency in autism is 38%. That's over taking into account 8 studies. Okay, so 38%. So, and then that matches up too with our 40% that we see as a response rate. So 38% will, if you do an LP, you will find cerebral folate deficiency. So, so that's a large number. So, that's more than a third of children with autism. You can, if you want to do the lumbar puncture, and I think that it's a lot to go through. So, I don't know that that's the case. But if you wanted to do that, if that's what you needed to be convinced in a child that isn't developing and is not responding to treatments, you can find an answer that will change that child's life if you do a lumbar puncture. We believe that's how I started out. I started out, as I said, doing lumbar punctures on kiddos. And then we started doing the FRAT test. And we, if it was positive, we gave the parents an option of to do a lumbar puncture or not to do a lumbar puncture. And you can kind of guess where most of them landed. Some people wanted us to do it, and that's where we have some of the data. But many didn't. They said, well, leucovorin is, safe enough that why don't we give it a try? And if it doesn't work, it doesn't work, and we can go move on to something else. And it's probably safer to try leucovorin than to go through a lumbar puncture.
Yeah.
And the lumbar puncture is pretty safe if it's done in the right hands, but you have anesthesia, you have a lot of other things that could cause complications. So, when you weigh the two, it seems that, well, maybe very much that a trial of leucovorin and using the FRAT test is important. I always advocate for using the FRAT test, looking, as I say, look for mitochondrial issues, B12 issues, and such, because these are all things that need that work together, in order to optimally treat the child. And I think you have to look for it because it's there and it could change people's lives.
Mm-hmm.
Thank you.
Great. Yeah, that letter left many parents confused. I think it's a great answer for all of their fears now.
Yeah, thank you so much.
Yeah, the long-term safety thing just really boggles my mind because, not only leucovorin do we have 80 years of experience, but we have thought folates are so safe that, at least in the United States, we've fortified our food with it for the last 30 years.
Yeah.
We've given it en masse. So if you don't think it's safe,
don't put it in the food.
Yeah. Actually, we got a question if high levels of folate can in any way still be risky. Can it affect glutamate levels in a harmful way? People are still afraid of this.
Yeah. So the great thing, we love B vitamins. And the reason why we love B vitamins is because they're what we call water soluble, which means at the end of the day, you pee them out. Your body automatically eliminates them. So, so it's a good and a bad thing. You have to take them every day to keep the levels up, but your body gets rid of them automatically. So that's what makes them very safe, especially for long-term use. Does it cause any problems as far as, at high levels of folates? There's been no studies that suggest that. Folic acid is different, okay? And we can talk about folic acid.
Yeah.
But reduced folates do not seem to have any negative effect, even long-term. People have been worried because we are giving, folate, long-term, whether it has long-term effects, and it does not seem to have any long-term effects. It was thought that, one of the concerns was that if you have cancer, right? Cancer loves folate. Okay, cancer eats up folate because folate's important for making new cells. So it replicates, very quickly with folate. So there's always been this scare that, maybe if you had folate long term, it's going to increase cancer risk.
We actually got the question exactly like that, yeah.
And for the most part, the studies have either been null or they've shown that it's protective. Because overall, if you take it, long term, it actually protects you against many types of environmental insults, and it improves DNA repair. So it's important for DNA repair. So it actually protects you, Of course, if you have cancer, you have to talk to your oncologist. That's something completely different. But in the long term, does it increase your risk of cancer? Absolutely not.
Okay, that's a great message. Many parents were worried about it and asked if we have cancer in family or if we have some tendency for tumors, is it still safe? So I understand that it's still safe.
Yeah.
Yeah, and actually, because for the most part, cancer is usually caused by some type of second hit by the environment, and folate, B12, other things are going to protect your body from environmental insults and actually improve DNA repair. So it'll actually be protective.
Okay. And also when treating with leucovorin, are there tests, maybe a routine blood test or any monitoring that should be done over time?
Yeah, there theoretically, that there's thought that it could affect the blood cells and such, but there's been there's been no data. People have looked at it. There's been no hard data that suggests that that's the case. As a really empirical matter when you actually look at it. I've had patients that have been on it, for 15 years. I still see some of my original patients that I started them on, and they're just doing wonderful on it. Yeah,
15 years without a stop, continuously. Wow.
Yeah.
Mm-hmm.
Yeah. Some people stop to see if they need it or not, and sometimes they do, sometimes they don't. But they usually do. Parents, parents have told me that that when they make up their budget for the month, it's rent, food, Leucovorin. Those are their top three. Because it's so helpful.
Mm-hmm. So what happens when they stop?
So, we know that. So in our first study, we did follow up some of the patients that stopped after the trial, and we found that, and this isn't a formal study, but we found that about half of them regressed, lost language pretty quickly.
Wow. Even quickly, not over a month.
Yeah. Over about a month or so. About a month or so, they lost skills, significantly, and the other half didn't. But it may, we didn't follow them off long term, so we don't know if it could have had an effect in the longer term.
Okay. Oh, yeah, that's interesting. Many people and many parents ask about it. What happens if we stop? Yeah. And actually, one of the biggest areas of uncertainty for parents is dosing. How do you recommend starting with folinic acid? Is there a default safe initial dose that is always recommended to start with?
Well, it's always, good to go slow, to increase slowly. As I mentioned, we do see some hyperactivity. So about 20%, it's not in every kid, about 20%, we see excitability and hyperactivity. And we know that this resolves in about 4 to 6 weeks, usually about 3 weeks, but sometimes up to 6 weeks. So we tend to increase it slowly. We start at usually half of the target dose. For most kids, that's going to be 25 milligrams twice a day. But for smaller kids, it's 2 milligrams per kilogram per day. And then we go up slowly. And what I usually do is I find that some kids longer term may need higher doses, but what we do is we start at that dose. And as I had said, in our studies, we give it 3 months to see a response. So I give it some time. We work on other things, of course. They have GI issues, mitochondrial issues, sleep issues. We work on those. If it seems like they've got some response, but not optimal response, we can increase it. So a lot of times we slowly increase it, see if it gives them another, bump as far as improvement in language. If not, you can always go back down. There's no harm done. But many kids, we seem to need to titrate it higher. And that's one of the things that we don't know, right? Right now, we're using dosing that's used for in oncology, in a completely different, disease. So we need to research that to see what the optimal dose is. But despite that, there's many kids that respond and really get benefit from it. So I wouldn't hold that back as a reason not to prescribe it.
So there is no like a magic number that if everyone will start with 2.5 milligrams a day and then slowly titrate, there is nothing like that, if I get it correctly.
No. And that's why, it's one of these things of, you have to do it carefully. It's not the autism pill. It's not a magic pill. It's a very important treatment that we have in our toolbox. But some kids can't take that second dose. I started, instead of getting it twice a day, the second at nighttime, I give it in the afternoon. As some kids that can't even tolerate it in the afternoon because it'll disturb sleep. So many of them just get it in the morning, possibly. Some kids need it 3 times a day. Sometimes it helps sleep, So, it's a very individualized, thing, and kids with autism are like that. They're very individualized. So you have to kind of slowly work on things to find out what's right for them.
Yeah. Is there like a correct way to increase doses? Like parents like guidance. So is there like, if anything goes well, then wait a week and then increase it a bit and then increase it a bit? Is there any kind of guidance like this?
Yeah, so I usually, like in the beginning, I wait 2 weeks between increasing the dosing. I'll get up to what's our, kind of theoretical dose that have been used in most of the studies, 2 milligrams per kilogram per day with a max of 50 milligrams per day. And I will, just stay there for a couple months and see how things work, because sometimes it is this slow increase, so you really want to know, how observe the child and see how they're improving. And then, then maybe start increase, usually, let's say every 3 months, maybe try to do an increase, double the dose, try to double the dose and increase it slowly over, I'd say, a month or 2, and see how that works for another month or so. Yeah. But is there any right or wrong way?
Yeah.
Nothing absolute. Yeah.
I have a question.
That's why we call it the art of medicine. It's you have the science and you have the art.
I read about MCAS, and many kids with autism are sensitive.
Most definitely, yeah. The mast cell is definitely a very interesting subset of kids with autism, and it's very interesting. It seems like they come together with a number of different things. We've seen, it seems like you have not only autism but other psychiatric disorders, mast cell, a kind of hyperextensibility. A lot of times, mitochondrial dysfunction, for some reason, all seem to come together in a lot of the cases. So it's never been described as a syndrome, but I think that's what we're starting to see. It's not. I'd say it's not a major subset, but I'd say it's a good 20% of kids with autism, 10-20%.
A very hyperactive or super sensitive kids will still use the same titration, or if you know in advance that they are very sensitive or very hyperactive, you will start very low since in advance you know that there could be problems here.
Yeah, no, I definitely would. The other issue is that a lot of the kids that are sensitive, we find some kids that don't really tolerate any B vitamins at all, and we find, and we're pretty sure this is related to something in the gut, because a lot of times what we'll do is they're getting such poor nutrition that we will, what we'll do is we'll sometimes give them, intravenous, vitamins to see if that will help. And it seems that they can tolerate either IV or sub-Q, like B12 and folate, or intranasal, so we think that it has to do with the gut, may have to do with the mast cell issue. Haven't quite figured that out, but that's definitely something that is something that we do see in some kiddos.
So IV can help with that.
So some kids, it's the problem is the practicality of doing IV, nutrition. But some kids respond really well to IV nutrition and IV. I should say nutrition of vitamins. We used to do NAC, glutathione, vitamin C, Myers cocktail, Leucovorin. Together, and some of them have a dramatic positive response.
Mm-hmm.
Of course, the problem is you can't do this, chronically. But it does tell us that it helps. The idea of it is not to keep them on like an IV, multivitamin, but to get their body to repair itself, so then they can take things orally.
To adjust, yeah. Okay. Thank you.
Yeah, we're also seeing as a community that many children are being treated, but in very low doses of folinic acid, like 1 or 2 or maybe 5 milligrams per day. Is it still expected to give good results in such doses? Will it just take longer to see results, or is it just not going to work?
Well, it's not going to be treating cerebral folate deficiency. So there are many other folate issues. That we see in autism. So it's probably treating some of those other issues. We see issues with the methylation and transsulfuration pathways, and so those respond to leucovorin and methyl B12. So that's another really important treatment. And by improving that, sometimes we see a dramatic recovery. One of the studies that I did early on when early in my career, I went to Arkansas Children's Hospital because I was recruited by a woman by the name of Dr. Jill James, who was really one of the pioneers in autism, that showed that we have that there's these methylation and transsulfuration problems in kiddos with autism. And so we have a study, open label study, that shows that methyl B12 and folinic acid improved glutathione levels and other transsulfuration levels, and improved their adaptive behavior. So there's other reasons for it to work.
Okay.
Thank you. A very practical day-to-day question is whether folinic acid should be continued during illness or fever.
Yeah, there's no reason to stop it.
Thank you.
Yeah.
And another question is, many are curious, how do you know when to stop increasing the dose? Is it based on side effects or when improvement becomes stable?
When you don't see any more improvement.
Okay.
With an increased dose.
Thank you. Are there any clear indications for cases where dose should actually be decreased?
Sometimes if you're seeing too much hyperexcitability, if you're seeing sleep disturbances, those would be reasons to decrease the dose.
Yeah, those are common questions that we get. And if a high dose is reached but no improvement is seen, how do you usually decide what to do next?
I usually look for other reasons. I'll be more aggressive. I kind of go over things to see maybe what I've missed, or what other directions we should go in. We also do whole genome sequencing on all of my patients. I do to make sure that we look at all of the genes. We look for any types of genetic abnormalities too. So we kind of go over things, and then if I'm not making progress with a patient, many times I'll refer to a colleague to kind of look over what I've done to see if I've missed something. Because I'm not always perfect. So definitely, we take it seriously, and we want to make sure that we've really done everything we can to really help them.
Thank you. And in which cases would you consider increasing the dose beyond 50 milligram per day?
In those that maybe have responded but have a lackluster response, and that they may need higher doses. We know that it seems like bigger kids and adults may need higher doses. And then we've also seen that there's this this thing called the soluble folate receptor protein, which seems to suggest that a higher dose is needed for response. So again, it's a bit of an art.
Thank you.
And if dose increases, if it causes hyperactivity or other symptoms, many parents are wondering what it's indicating. It's a good sign, it's a bad sign, dose should be increased, decreased. Is a reaction is better than no reaction at all?
So it depends on the formulation, right? As I had mentioned, if it can be due to the additives. If it's due to the additives, it's not good. If it's due to the medication, it may be a good sign that that the brain is awakening. Yeah.
Mm-hmm. Mm-hmm. And supplements can feel very overwhelming for many families. When and how much B12 should be added to the treatment? Is there a specific form that you recommend, like methyl B12, hydroxy B12, maybe adenosyl B12? There are so many out there in the market.
So I go with what the research says, and the research in autism, for the most part, has been on methyl B12. Dr. Rosian and I wrote a systematic review and meta-analysis about 3 years ago on B12 also. And so the great number of studies has been on methyl B12. So that's what we stick with.
Mm-hmm. And there are cases where you still recommend other forms, or you stick with methyl B12 always?
I usually stick with it if it causes side effects like hyperactivity. We might try a different form. We do something a little special in the sense that we do the. So for young kids, we find that you have to really do the injections because their body just can't, absorb the amount of B12 that they need, and we combine it with Leucovorin or Folinic Acid, and we find that when you combine the two together, really you get more of an effect and less side effects. Mm-hmm. So if we don't see that, if we're seeing some type of side effects we don't expect, we might try and change the form.
Oh, and there are maybe any general dosing and titration guidelines for B12 when it's combined with folinic acid?
For in our study, we found that it was used about 75 micrograms per kilogram.
By injections or orally?
By injections, yeah.
Oh, there are any recommendations for oral dosing, or there are no such?
Yeah, I usually use about 5,000 micrograms.
Oh, really?
Mm-hmm. Yeah. And again, you adjust it depending on the patient.
Mm-hmm. And do you generally recommend adding B12 regardless of blood levels? Is it a must?
You don't measure blood levels, yeah. You have to measure functionally what's happening. So I usually measure fasting homocysteine.
Mm-hmm. Okay.
And that functionally tells you what's actually going on in the methylation pathway.
But B12 is always added regardless, or only according to this test?
I usually just go according to the test, yeah.
Okay.
But it's, I'd say, in about 80-90% of patients it's needed.
Oh, I see. And if you had to simplify, are there any core supplements that you consider a must-have?
You mean that you must have? Yeah, we start with a multivitamin that's made for kids with autism. There's some good ones. so that you really cover all of your bases. Yeah.
Mm-hmm. Yeah, I can show that we are personally using the Spectrum Needs multivitamins that we really like. Anything that you can tell us about this product?
Yeah, I mean, Spectrum Needs is made to fill in all those gaps. It's designed similar to the Autism Nutritional Research Center Essentials, which was developed by Dr. Adams at ASU, which he's done several double-blind placebo-controlled studies on that vitamin. His vitamin is not flavored, so sometimes it's a little bit of a challenge. But either one of those two, I think, really fill in the needs for kids with autism.
Mm-hmm. Yeah, and still supplements are a major concern for parents. They always don't know what to do, how much to add. How do you decide what to give, when to give it, how much to give?
Again, I relate it to blood tests and symptoms, what can be improved or what symptoms they seem to have.
Oh, I see. And so, like, generally adding magnesium, NAC, things like that. So there is no like a general thumb rule that fits all.
Unfortunately, not.
Yeah.
Very complex.
Okay, guys, I got to run and see some patients. So, and thank you guys for having me.
Thank you so much.
Thank you very much. Thank you for joining us, and we really appreciate it.
It's a big honor for us.
Yeah.
Thank you.
Yeah,
my pleasure.
Thank you.
Thanks for getting the word out.
Yeah, we will.
Definitely.
Take care.
Take care.
Okay.
Bye-bye.
Bye-bye.
Bye.